Hi, everyone. Thank you so much for joining today's session. So, we all know that antimicrobial stewardship has been recognized as one of the effective strategy to optimize the use of antimicrobials. And the guidelines from across the globe endorse the key role that clinical pharmacists play in this program. But as we know, in India, clinical pharmacy is still in an infancy stage and it's still evolving. And it's really great to see that, more and more hospitals are implementing clinical pharmacist-driven antimicrobial stewardship activities. But the question that I always have is how do we actually convince the hospital leadership to create more opportunities for pharmacists in their hospital? How do we show the economic impact of what pharmacists can do in antimicrobial stewardship programs? So this is exactly what we are going to discuss in today's session. And it is with great pleasure that I invite Dr. Karan Raja for this session. So to just briefly introduce Dr. Raja, he is a clinical pharmacist practicing in infectious diseases, antimicrobial stewardship, and critical care since 8 years post-residency training in the US. He's a board certified pharmacist in pharmacotherapy, infectious diseases pharmacy, and HIV pharmacy. Dr. Raja is also an adjunct faculty at a School of Pharmacy and a clinical preceptor for pharmacy students and pharmacy residents. He also has numerous publications to his credit and is actively involved in local and national organizations. And he's also very much passionate about improving pharmacist roles in different clinical pharmacy services and to uplift the pharmacy workforce as a whole. So thank you so much, Dr. Karan Raja, for collaborating with FCPI. And the stage is all yours. Over to you.
Thank you so much. It's an honor to be here and an honor to present to you all.
You can go ahead with your presentation.
Okay, wonderful. Once again, thank you everybody for allowing me to present today. The topic of today's presentation is the economics of clinical pharmacists in infectious diseases and antimicrobial stewardship. These are some of the abbreviations that I will be using in today's presentation. Most of them are relatively common. I'd just like to highlight on the left side, ICER, or Incremental Cost Effectiveness Ratio, and on the right side, SAAR, Standardized Antimicrobial Administration Ratio. The objectives of today's presentation are to first define antimicrobial resistance, antimicrobial stewardship, and antimicrobial stewardship programs. We will then describe the vital role of antimicrobial stewardship pharmacists, evaluate the economics of stewardship programs, and evaluate some cost-effective interventions. Next, we'll take this information to create a value proposition that builds stewardship pharmacists into hospital costing models. And lastly, we will compare and contrast successful and various implementation strategies. Antimicrobial resistance is really a threat to global health, food security, and development that's driven primarily by the overuse and misuse overall of antibiotics. In the US, more than 2.8 million antibiotic-resistant infections and more than 35,000 deaths are directly attributable to antimicrobial resistance per year. On a global scale, Africa and Asia bear the heaviest resistance mortality burden. Studies have shown and estimate that there will be a $1 trillion increase in global healthcare costs by 2050 due to resistance. This has led organizations like the World Health Organization to put a call to action on antimicrobial resistance, and organizations like the CDC to really recommend implementation of antimicrobial stewardship programs. So let's look at some consequences of not having a stewardship program or inappropriately managing resistant infections and leading to hospital-acquired infections. We can divide this into tangible and intangible costs. The tangible costs include prolonged treatment duration, hospital length of stay, greater resource utilization like PPE, higher drug costs, and increased risk of adverse drug events. The intangibles include mental pain and emotional suffering for patients that are away from their families for extended periods of time, a greater risk of morbidity, mortality, and decreased productivity as a society. So let's look at, again, if we don't have a stewardship program, you increase the risk of hospital-acquired infections. If you don't have effective infection control programs, the patients that have no hospital-acquired infections have a mortality rate of about 2%, a length of stay of just under 5 days, and a cost overall of care of nearly $38,000. In contrast, patients with hospital-acquired infections have a mortality rate of over 12%, length of hospital stay of nearly 20 days, and a cost of care approaching $192,000. Let's dig a little bit deeper into the consequences of not having stewardship programs and not managing resistant infections appropriately. Hospital lengths of stay can increase by 24%, which translates to about 7.5 to 19 excess days. Cost of care can increase by 29%, which equates to $21 to $34 billion per year. There's a risk of a $3.4 trillion decrease off of the global GDP by 2050. Mortality risk increases by 1.84, readmission risk by 1.49. Studies have shown and predict a 24 million people, in addition, pushed into extreme poverty by the next decade due to resistance. And managing resistant infections inappropriately can increase the risk of C. diff, which can cost upwards of $24,000 in excess per case. So antimicrobial stewardship programs are founded on having the right diagnosis, drug, dose, duration, and evaluating opportunities to de-escalate. The goal here is to measure antibiotic prescribing and use in a particular facility and implement strategies to modify that prescribing that better aligns with evidence-based recommendations, all in the hopes of having outcomes like improved patient care and quality of life, optimized treatment duration and decreased hospital lengths of stay, curbing resistance, preventing hospital-acquired infections, decreasing morbidity and mortality, and overall controlling antibiotic and infection-related treatment costs. The pillars of effective stewardship programs are listed on this diagram. So we need to have good technology, the right people involved in care, government support, and national and local leadership support, and of course, financial support. So internal and external funding are important to advance stewardship activities, as the upfront cost associated with additional resources needed for a stewardship program can actually be a potential barrier to implementing the stewardship program. This slide reviews the people and the teams that are involved in effective antimicrobial stewardship programs. And of course, being a pharmacist myself, I want to highlight the very important role of the pharmacist in antimicrobial stewardship programs. The CDC core elements of antimicrobial stewardship in an acute care setting highlight the importance of having a pharmacist on the stewardship team. The CDC core elements of outpatient antimicrobial stewardship also highlight the importance of having community-based pharmacists to educate patients and to be involved in stewardship. And again, on a global scale, the World Health Organization has a low and middle income country stewardship toolkit, which also highlight the various roles and expertise of stewardship pharmacists. So this infographic shows that pharmacists, including stewardship pharmacists, but also community internal medicine pharmacists, can contribute to stewardship activities across the continuum of care, from the emergency department to the hospital, to the discharge and transitions of care setting, and to the outpatient setting as well. Stewardship pharmacists can help reduce unnecessary antibiotic use, which is often a major driver of healthcare costs, promote use of narrower spectrum agents, which generally speaking are less expensive than broad spectrum alternatives and can minimize the development of resistance. We reduce antimicrobial related adverse events, especially C. difficile infections, and encourage an overall cost-effective care, primarily by shortening hospital stays. So now let's get into the actual economics and the business proposal. So far, we've seen the consequences of not having a stewardship program, which again are often led or extremely supported by pharmacists. But having a stewardship program also costs money. So we have to show that pharmacists and pharmacist-led ASPs can be financially self-sufficient, meaning we offset or reduce the cost. And at the same time, we have to provide a high value to the healthcare system by improving care and improving outcomes. So the idea here is to have a value-based approach and a cost reduction strategy. In other words, we have to spend more on some services to then reduce the need for others. And that's the best approach. So if we optimize antimicrobial use, this is anticipated to improve patient outcomes, lower resource utilization, and lower associated costs. This will then increase the amount of health outcomes per dollar spent, which translates to an increase in value, which should support an increase in economic sustainability of the stewardship program. Now, looking at it from a hospital pharmacy perspective, more than 50% of antibiotic use in an inpatient setting is considered unnecessary. But antibiotics comprise 30% of hospital pharmacy budgets. This really propagates resistance and increases cost. Studies have shown that stewardship programs can decrease antimicrobial use by 22 to 36%, which translate to $200,000 to $900,000 per year in savings. Smaller facilities can also realize upwards of $150,000 a year in savings. Generally, the direct cost savings come from antimicrobial procurement costs, so the cost of the drugs themselves. Indirect cost savings come from this length of stay reduction in diagnostic tests, and overall management of resistance, as we talked about earlier. But measurement of stewardship pharmacists' economic impact and financial benefit are crucial to make sure we actually secure program support and increase our resources down the line. It's important to document the number and type of interventions performed, evaluate the cost savings and the cost avoidance, which we can use data from published literature, but we'll go over this in the second half of the presentation, and to evaluate clinical outcomes. One study estimated that a stewardship pharmacist can save about $700 per intervention. And the goal is to take those cost savings and reinvest it to offset the cost of the stewardship pharmacists themselves and to incentivize sustainability of the program. But we also have to realize that there is a bit of a ceiling effect with these interventions. So in the beginning, we can definitely demonstrate significant cost savings and value. But it's important to keep identifying various ways to continue reducing costs or then contribute in other ways that add value to the healthcare system or to patients and the healthcare team. So now let's move in to the actual value proposition. So let's look at some cost-effective interventions that can be used to demonstrate the stewardship pharmacist value when we build into hospital costing models or propose hospital costing models. So this slide shows various stewardship interventions that pharmacists can be involved in. On the y-axis, we have increasing intensiveness of the intervention, and on the x-axis, we have the anticipated financial impact. So for example, if we look at the top right, we see RDT, or rapid diagnostic test. This intervention is very labor and resource intensive, but can have huge financial impacts. In contrast, if we look at the center where we see IV to PO, this is considered to be a low intensity intervention, but it can still have a moderate financial impact. And throughout this presentation so far, I've used the term cost. And when we develop a value proposition that is founded in antimicrobial costs, it's important to examine the actual nuance of the term cost. So antimicrobial costs can be based on the amount that's purchased, the amount that's dispensed, or the amount that's administered. Expressed as an absolute dollar value, a percent of total, so the percent of total antimicrobial use when we're looking at specific agents, or it can be normalized into per patient days. Tracking can occur monthly or annually. It can be hospital-wide or for specific services. It can be for a specific drug or a drug class, or based on indications. The pros of using cost is that it's easily understood and relevant to administration. And ultimately, administration is the one that often makes the decision on our value proposition. It is viewed favorably when we offset the cost of our position and our program. The data is generally pretty accessible, and the data can be normalized to allow comparison between services, between hospitals, and help us identify areas for intervention. The cons of cost are that the purchased and dispensed costs are really surrogates for the actual usage. So what did the patient actually receive? And this can be difficult to retrieve, especially if we don't have an electronic medical record. Costs can also fluctuate. So due to inflation, changes in contracting, availability of generics. And so the cost reduction of a particular intervention may not actually reflect a pharmacist's intervention. Lastly, some antimicrobial costs for service level data may be difficult to retrieve based on EMR capability. So when we're developing a value proposition of a particular intervention, we want to take a few steps to make sure that we evaluate this in the best way. So some interventions achieve easily measurable cost savings, but others can be a little bit more complex. So what I recommend is that the first step is to calculate the anticipated cost savings or cost avoidance with a particular intervention. So we want to estimate the impact of that intervention based on current usage patterns, and that helps us garner initial support. So if I am going to do a certain intervention, I anticipate this much cost savings or cost avoidance to help the team actually support your proposal. Step 2 is post-intervention. You calculate the actual cost savings based on results of a pre-post study using the same estimate values if we are using published data, which we'll talk about in a few slides. And this will help you establish the value. This will help us justify additional financial and personnel support when we actually show a cost savings or cost reduction or cost avoidance. Now, the information in step 2 can be based on specific patient-level pharmacist interventions that we conduct, or it can be aggregate and facility-wide usage data. So for example, we can look at antimicrobial utilization using days of therapy. So we look at the days of therapy of a particular antibiotic times the costs per day, giving us the total cost avoided. So the first cost-effective intervention we'll discuss is intravenous to oral conversion. So basically, it's conversion of an intravenous antimicrobial to its highly bioavailable oral formulation. Generally, and especially in the US and in our facility, we have pharmacy-managed automatic IV-to-PO protocols for drugs such as doxycycline, azithromycin, and trimethoprim sulfamethoxazole. So step 1 here is to estimate the cost savings by assessing historical usage of a particular agent or a group of agents to determine what proportion of the treatment days during which IV was used, PO would have been appropriate. So for example, if we're treating a patient with community-acquired pneumonia and they are being treated with 7 days of IV levofloxacin, but on day 3, they were clinically stable, able to tolerate oral medications. So if we had converted the patient on day 3, we would have avoided 4 days of therapy of IV levofloxacin times the cost per day, giving us the total cost avoidance anticipated. Step 2 would be to directly measure the cost savings by tracking IV-to-PO conversions, again, directly initiated by the pharmacist, or by estimating impact by looking at IV-to-PO rates pre versus post-intervention. Next, we have redundant therapy, defined as having antimicrobials with unnecessary, duplicative, or overlapping spectrums of activity. This is a relatively easy target and can help reduce drug costs as well as resistance. Actions include consolidation of agents, de-escalation, or discontinuation. Examples of situations where we can use this intervention include double anaerobic activity, and I see this all the time. We see agents like carbapenems or piperacillin tazobactam combined with metronidazole in intra-abdominal infections. Step 1 here would be to assess historical data on redundant therapy and estimate the anticipated cost savings. And step 2 is the assessment of actual cost savings after implementation. Next, we have de-escalation, which is defined as the change from broad to narrow spectrum agents, of course, in the appropriate patient. The direct cost saving comes from the actual drug cost. So broad spectrum agents, again, are generally more expensive than some of our narrow first-line agents, especially when we talk about the novel beta-lactam, beta-lactamase inhibitors. The indirect cost savings come from a decrease in resistance, facility costs, streamlining prescribing, and potentially reducing waste. Actions include formulary restriction, prospective audit and feedback, which is very often conducted by the pharmacist, the stewardship pharmacist, and pre-authorization interventions. Examples here include de-escalation of the novel beta-lactam, beta-lactamase inhibitors in the appropriate patient. Step 1, assess historical data on broad-spectrum use, and this can be done through the SAAR categories. And we estimate anticipated de-escalation opportunities and the associated cost savings with that intervention. Now, one point to note here is that from past experience and in most people's experience, de-escalation conversations with providers may or may not always be accepted. So what we recommend here is to have a range of cost savings. So that accounts for the variable rates of acceptance. Step 2 is to look at the actual cost savings after implementation. Again, this can be done on patient level or through aggregate antibiotic use. Next, we have reductions in performing therapeutic drug monitoring. So a lot of the antimicrobials that we use come with additional TDM expenses, and monitoring is often done at the wrong time or more frequently than necessary. So this results in unnecessary lab costs. The goal here is to reduce unnecessary testing through clinician education or through direct pharmacist intervention on specific patients. And we also can take this opportunity to provide early and accurate dose optimization interventions. Example agents include vancomycin, the aminoglycosides, and voriconazole. Step 1 is to look at the anticipated cost savings, so the cost of one TDM test times the total number of tests that were likely to be avoidable in a retrospective view. Step 2 is to look at the actual and direct cost savings by looking at pharmacist interventions, or estimating the cost savings by looking at total TDM tests and cost pre versus post intervention. Next, we have antimicrobial allergy assessment. A significant proportion of the population, especially in the US, report inaccurate or incomplete drug allergy histories. In the US especially, beta-lactam allergies are often implicated unnecessarily. So 10% of the US population reports a beta-lactam allergy, whereas less than 1% are likely to be truly allergic, meaning having an immediate IgE-related reaction. The action here is to conduct a thorough allergy history with appropriate documentation, and in the appropriate patient, conduct direct drug challenges or penicillin skin testing. This would impact penicillins, cephalosporins, and carbapenems. Cost savings can be looked at in a few different ways, but for example, we can look at the total non-beta-lactam days of therapy and their associated cost that were likely to have been avoided if allergy assessment and drug challenges and PSD were performed. Step 2 is to directly measure the cost savings by tracking days of therapy avoided, or to estimate the actual cost savings by comparing days of therapy of non-beta-lactams versus beta-lactams pre versus post-intervention. Now, many studies have shown that the benefit of a thorough allergy history and penicillin skin testing can positively impact hospital lengths of stay, infection cure rates, and so whatever data we have here is likely an underestimate. So doing step 1 and step 2 is a way to garner initial support, and otherwise we can take published data on length of stay avoidance and the associated costs and build a much stronger costing model here. Next, we have a reduction in overall antibiotic use. This is defined as having reductions in facility-wide antimicrobial use over time, which can include all antimicrobials or specific SAAR groups. And this is usually done through a multi-pronged or multifaceted set of interventions. Of note, again, when we're looking at expenditures associated with a reduction in antimicrobial use over time, it's important to keep in mind that the drug cost can change, whether that's the change in actual drug cost, availability of generics or contracting changes. Actions are various and usually multifaceted. Examples include pre-authorization or changes in formulary. Step 1 is to assess historical data on total antimicrobial consumption and their associated cost, and then estimate the percentage reduction with an intervention that we're proposing. Step 2 is to look at the actual cost savings after implementation of that set of interventions. Next, we have the clinical benefits associated with cost savings. So a lot of the interventions we recommend and we implement as stewardship pharmacists result in indirect cost savings through positive clinical outcomes. Now, the pitfalls that we should be aware of here are that sometimes it is rather difficult to attribute an outcome directly to pharmacist intervention. Also, it's tough to assign specific costs to a clinical outcome. And lastly, it's important to try and control for concomitant interventions, such as changes in census, acuity, or infection control practices. Actions here include IBD-PO, discharge antibiotic stewardship, and antiretroviral evaluation. These interventions can help improve treatment success, reduce length of stay, reduce resistance, and reduce adverse drug events or toxicities. Step 1 is to assess historical data on clinical outcomes, and then estimate the anticipated cost savings with a particular intervention. So what I recommend here is to take published estimates that assign a cost to a specific clinical outcome. And then in step 2, we try to identify the actual cost savings after implementation using that same estimate value. And we can make any adjustments as needed, for example, for inflation. Last, we have inpatient and outpatient treatment guidelines. These are defined as having standardized antimicrobial prescribing guidelines based on national guidelines, based on local resistance patterns, based on formulary, based on drug availability and drug cost. The goal here is to streamline empiric prescribing, which should help improve outcomes, reduce waste, and increase consistency among the disciplines. We want to create an easy-to-use and accessible treatment guideline. One example is an interpretation of rapid diagnostic testing. Step 1 is to assess historical compliance data with national or local guidelines if they exist, and then estimate the cost savings. So that can be improved clinical outcomes or reduced waste or reduced length of stay. Again, using the published estimates that we talked about during the last slide. And step 2 is to assess guideline compliance rates and cost savings after implementation, again, using the same estimate values. So this slide lists a few quality improvement projects that I've done over the years. And the reason for this slide is that it's important to note that a lot of quality improvement projects that we do as part of our daily stewardship activities as a stewardship pharmacist or stewardship program can actually have financial analyses or financial components built right in. So for example, if we were assessing the clinical benefits of a standardized conversion to extended infusion beta-lactam, we can also take that study and add in the components of reduction in waste, streamlined formulary, or reduction in the number of dosage forms and fluid bags that we're carrying. This can help highlight the economic impact as well. Now let's look at some published data on cost-effective stewardship practices. So this slide reviews rapid diagnostic testing data. So Lockwood and colleagues implemented MALDI-TOF with clinical pharmacist intervention in Texas. Time to therapy adjustment decreased from 75 to 30 hours. Hospital cost per patient decreased by $3,411 pre versus post intervention. McCarthy and colleagues implemented a pharmacist review and intervention on Veregene results 24 hours a day, also in Texas. And Veregene is a rapid diagnostic test, usually for bloodstream infections. The time to change to targeted antimicrobials decreased from 18 down to 8 hours. And in the post-intervention group, antibiotic days of therapy decreased from 10.5 to 9 days, and ICU length of stay decreased from 3 to 1.4 days. And lastly, we had Pliakos and colleagues who implemented and assessed rapid diagnostic testing for bloodstream infections with or without stewardship intervention conducted at Brown University. And what they found is that MALDI-TOF with stewardship intervention was the most cost-effective strategy, with savings of nearly $30,000 per quality-adjusted life year. They also estimated a prevention of 1 death per 14 patients with a suspected bloodstream infection as compared to conventional lab methods without stewardship intervention. The study authors concluded that rapid diagnostic testing with stewardship intervention had an 80% chance of being cost-effective, versus rapid diagnostic testing without stewardship intervention had only a 41% chance of being cost-effective. So overall, implementing a stewardship team, implementing a stewardship pharmacist can result in substantial healthcare savings. Next, we have this slide depicting various penicillin skin testing programs throughout the US. So King and colleagues implemented penicillin skin testing in 37 patients in New Jersey. Patients with a negative skin test or oral challenge were changed to a beta-lactam agent. The cost of antibiotic therapy after skin testing was $4,800, but the cost of therapy if PST was not done, so the cost of original therapy, would have been over $20,000. The cost of the penicillin skin test itself, including the time required to conduct the testing, was about $4,700, and therefore there was still an overall cost savings of nearly $11,000. Heil and colleagues had an ID fellow-based penicillin skin testing program in the US. They evaluated 90 patients and identified that Estreonam use decreased from 3.4 down to 1.9 days of therapy per 1,000 patient days. This resulted in a cost savings of about $26,000 per year. And Ramawi and colleagues conducted PST in 146 patients and identified a cost savings of $225 per patient during a 5-month period. So the common theme here is that penicillin skin testing programs are at least cost neutral when we compare drug acquisition cost avoidance, and would actually be cost effective when we also include the reduction in length of stay, improved clinical cure rates, and reduced risk of readmission. And next, we have an assessment of various other practice models. So the first 2 studies assessed ID and non-ID pharmacist impact on discharge antibiotic prescribing. And if we look at the Mercuro study, patients in the post-intervention group, so with pharmacist intervention at discharge, were more likely to have optimal antibiotics prescribed with an odds ratio of 5.63. And what's interesting is that the results were consistent between academic and community-based hospitals. So even in resource-limited settings, we may still see an impact of having a pharmacist in this position. The bottom 3 studies are data from Spain, Sub-Saharan Africa, and the Middle East, all demonstrating a reduction in antimicrobial consumption and cost with stewardship interventions, and in particular, stewardship pharmacists. This last study is a systematic review conducted by Nathwani and colleagues that I found extremely helpful. It evaluated various stewardship interventions and found that these various interventions had various impacts on operational costs. And this is where that idea came from, that we have to spend some money on certain services to reduce the need and the money spent on other services. So the study overall found that stewardship interventions saved $732 per patient, and these results were similar across US and European studies. The main driver of cost savings was that reduction in length of stay that we discussed. And the review found that savings were higher when we had a comprehensive stewardship program, of course, with prospective audit and feedback plus pre-authorization. And now the main part of the presentation. So let's look at the implementation science. So how do we take all of this previous data and these recommendations and actually build a stewardship pharmacist role into hospital costing models? So the first is who do we talk to? So I recommend setting a meeting with your key stakeholders, and this can be done through an introduction, an internal reference if you already work at that facility, or through a cold call even. You want to talk to facility leadership. Target people that would understand and value your proposition. You want diseases, pharmacy, hospitalist, surgery, etc. I recommend starting perhaps with the C-suite, so chief nursing, finance, quality, or academic officers, and of course involve and speak to the head of departments of ID and stewardship in medicine. And I also recommend taking a little bit extra time to discuss the mission and the goals with people that are rather refractory to change, because there is a bit of social psychology involved in setting up this position and actually maintaining it. And what is it that we're going to talk about? I recommend having a gap analysis. So what are the opportunities that you have found in this hospital? And even if you don't know the specific opportunities, there are usual universal needs of a particular hospital or a particular healthcare setting. Go in with stratified and realistic, achievable outcomes and solutions. And have an idea of the anticipated cost in and the cost out. So what is it going to cost to get this position of a stewardship pharmacist, or to get a stewardship program up and running, or to get a particular intervention implemented? And also have an idea of how many FTEs we're talking about. So some studies have estimated that usually there's 1 MD to 3 PharmDs as a ratio. But if we look at just the pharmacist perspective, one study assessed the need for PharmDs per bed size in stewardship and found that we need 1 pharmacist per 100 beds, 2 for 500 or more, or 3 for 1,000 or more. And why are we doing this? Why are we even getting involved in stewardship in the first place? So we've shown that pharmacists can elevate patient care. We can help curb resistance development and propagation globally. We have significant demonstrations of improved clinical outcomes and optimized resource utilization. And all of this can help decrease costs on a societal and global level. And of course, we want to establish the integral role of stewardship pharmacists. We all know our training. We all know how intensive our training is. And of course, we can contribute to this. We want to establish that value. And how is it that we're going to actually implement this? I recommend having a succinct but focused and robust meeting discussion. And always, I recommend starting with the end. So what is it that you're asking for? And then you can talk about how and why. You also want to show a depth of understanding. So what speaks to each audience member? So the chief financial officer, of course, wants to hear about the money. The chief medical officer wants to hear about the clinical outcomes. And if there is a small opportunity, try and conduct a pilot program. Positive results from a pilot program can help propagate that self-sustaining stewardship program. Presentations can be verbal, it can be a slide deck, it can be a handout. It really depends on who you're speaking to and how much time you have. It can be as short or as detailed as you feel comfortable. So the planning and early stages first begin with you. You must develop an understanding of foundational stewardship and ID pharmacy. So this can be done through residencies, fellowships, or stewardship certificate programs, which are offered by various institutions. You want to have earnest discussions with pharmacy directors and pharmacy managers first. At the end of the day, you're a pharmacist, and you want to make sure that your department supports your initiatives and your efforts. It is extremely important to have a physician champion that will understand the importance of your role and actually value pharmacist impact in stewardship. From my experience, that has been the key step and the key determinant in any pharmacist success, is having that physician champion that really values you. You also want to gain support and trust of the C-suite. Again, administration will ultimately have the final say on if a position is approved and what the scope of practice will be. Conduct and critically appraise a gap analysis. You want to assess the gaps in current stewardship practices or the current antimicrobial use landscape. And lastly, put a number on it. So consider the financial value of each intervention to the hospital, to patients, and to society, and then compare it to the cost of resources that are utilized or going to be utilized. So some studies have already done the work for us to establish a working budget or an idea of how much money will actually be required. During the intervention period, we want to make sure to demonstrate the stewardship pharmacist's crucial role to leadership, perhaps through a pilot program. You want to target high impact and low effort interventions first, like IV to PO, to initially get the ball rolling and establish the success. I also recommend engaging in handshake stewardship. So that is defined as having face-to-face conversations and intervention with various providers. It's important to monitor progress in real time and then pivot as needed. When we're practicing in stewardship, sometimes we have an intervention planned, we have every piece of that intervention set up, and we realize it's really just not going according to plan. It's not going in the direction we wanted it to. We're not getting the results we anticipated. So it's important to know that in real time and change. I also recommend celebrating the wins and losses. The losses are these pain points and learning points. That's what's going to help us grow. And lastly, please, in our pharmacy school, we were always taught document, document, document. You want to maintain a portfolio of your activities, looking at financial analyses that support the stewardship program, support your position as a stewardship pharmacist, and eventually allow for program expansion. Post-intervention, it's important to gather data and compare pre and post implementation data, as we talked about in the previous slides, conduct stats if necessary. The goal initially is to at least demonstrate cost neutrality and or then cost effectiveness. And then you want to re-engage the team with positive feedback and review opportunities for improvement. And one thing that I didn't do before, and I highly recommend all of you to do, is to actually market the program, market your successes within and outside of your facility. And in this last section, I have a case study. And the purpose of this case study is to really show everybody that this all takes time. It can take time for all of these interventions and all of this data to actually come to fruition. So this is a realistic example of how an ID pharmacist role can develop over time. So in 2008, we had basic ID clinical pharmacy services that began with pharmacy managed IV-to-PO, automatic renal dose adjustments, some of those low intensity, moderate financial impact interventions. In 2011, we implemented a stewardship intervention targeting carbapenem usage. In 2012, we had development of a clinical pharmacy council with ID pharmacy oversight. In 2014, we had more focused ID pharmacy services with a stewardship pharmacist. In 2015, we finally introduced the pharmacy to dose program, starting with vancomycin. In 2016, we had ID clinical pharmacy specialists have a dedicated role and dedicated FTE. And we had implemented all of the CDC's core elements of antimicrobial stewardship. In 2017, we had the development of a system-wide pharmacy ID collaborative, and our local stewardship program at that point branched off from the infection prevention and infection control department. And we also introduced the beta-lactam allergy assessment program at our hospital. In 2018, we had development of a system-wide ID collaborative, local introduction of rapid diagnostic testing, and a stewardship intervention targeting enterococcal UTIs. In 2019, our stewardship program finally began to expand. We had various ASB interventions, one targeting renal preserving empiric antibiotic regimens, and the other targeting utility of rapid diagnostic testing in gram-negative bacteremia. In 2020, after all of this work, our stewardship program won bronze at the state level. But we were determined to keep going. In 2021, we had development of a system-wide, a healthcare system-wide antimicrobial stewardship, microbiology, and pediatric stewardship collaborative that was multidisciplinary. Our local stewardship program at this point won gold at the state level. We implemented a stewardship intervention targeting skin and soft tissue infections and osteomyelitis with long-acting antimicrobials, and we expanded our allergy assessment program. In 2022, we finally established interstate research partnerships and maintained gold at the state level. In 2023, we had system-wide multi-specialty initiatives. Our stewardship program maintained gold at the state level again, and we implemented a discharge antimicrobial prescribing intervention. And now in 2024, ID Pharmacy finally joined various system-wide global health initiatives. So this presentation gave me an opportunity to reflect myself. So it's very important to have an effective pharmacist-led or pharmacist co-led stewardship program to demonstrate financial benefits. So what worked for us? Keeping the next steps in mind and beginning planning and engaging KOLs, key opinion leaders, early on is very important. Soliciting their feedback and actively listening to various perspectives. Starting small, starting with the low-hanging fruit like IVDPO and renal dosing is a great place to start. These interventions are generally the least invasive, and then we can build on those successes. Engaging key stakeholders at every step of the way. You want to make sure that they all feel like a part of the process. And understanding what motivates the audience. As we talked about, the chief financial officer would rather hear about money generally, and outcomes are important to the chief medical officers. And you want to demonstrate yourself, the stewardship pharmacist, as a part of the global solution to antimicrobial cost and antimicrobial resistance. Share your successes and highlight the role of the stewardship pharmacist. And ensure that the financial outcomes are very visible. This is something that I didn't do early on. So what didn't work? Attempting to control prescriptive autonomy. Telling providers what they can and cannot do is not a successful strategy. Setting unrealistic goals and expectations, not data gathering. And then overlooking foundational pharmacy practice. At the end of the day, you are a pharmacist and you want to make sure that you contribute to pharmacist interventions. Moving forward without a plan. And identifying as this antibiotic police or coming off as this antibiotic police. You want to identify yourself rather as an accessible and supportive resource that has the same shared goal to improve patient outcomes. And lastly, being behind a phone or a computer, I thought was very ineffective. Go see the patients, have face-to-face communication with providers. That really enforces that we are a team and we're in this together. Thank you so much for your time and attention, and I'm happy to take any questions.
Thank you so much, Dr. Raja, for that very elaborate and but very crisp and very clear presentation on a very important topic that's of of a lot of use to us. I actually have a few points that I would actually like to discuss with you further. So the first is you mentioned about how the different cost variables that we could use to actually show the benefit of pharmacist role in the program. So if you would be already knowing this, but in India, we don't really have a pharmacist-led stewardship model. We usually have pharmacists participating in clinician-led stewardship programs. So my question is, like, in those cases, how do we actually attribute the cost of the economic benefit of that stewardship model to necessarily attributable to the role of pharmacist in the program? So how do we connect that? And how do we convince the hospital administration that pharmacists also played a role in getting that economic benefit?
So that's a very good question. And I think there's not one straightforward and simple answer to that question. But the first thing that comes to mind is having that physician champion that supports you. Because I found myself in this position before. And in those times, that physician has gone to administration themselves and said it was the pharmacist that had done these interventions. So having
Right.
that support is very important. Two,
Right.
there are a lot of studies that look at antimicrobial usage trends, and they look at pre-stewardship program, then when there's an active stewardship program, and then when a pharmacist joined the stewardship program. So that can help you delineate the pharmacist intervention as well. And lastly, we can look at opportunities that are directly under the pharmacist's control. So for example, IVDPO at our institution is directly under the pharmacist's control. So in these cases, we can look at pharmacist-specific interventions instead of global trends.
Right. I think that's very important because as time progresses, it's important that pharmacists start taking up at least low-hanging interventions to be pharmacist-led. So I think over time, pharmacists need to take that initiative to do certain interventions on their own. So even in our hospital, when we started stewardship, it was all clinician-led, but gradually the team was ready to give us certain interventions, like you said, double anaerobic coverage. That was an intervention which pharmacists could do it on their own. We didn't have to consult our physician to make our recommendations. So over time, I think pharmacists need to take up initiatives on their own to actually show their impact in a better way. The second thing that I wanted to discuss was in India, especially whenever we talk about improving pharmacists' role in stewardship, one of the biggest I wouldn't say criticism, but because comment that we get is pharmacists here are not trained enough. So they don't have a good ID training. So we don't have a lot of ID pharmacists like you have in the US. So we have a few board certified pharmacists, but it's still very little. And the opportunities that we have for actually training the pharmacist in India is also just coming up. So I really liked the point that you mentioned where you said you need to, put in the cost in some places to actually get the benefit somewhere else. So can we also, so is there a provision to actually also, communicate to the hospital administration that they should also invest in pharmacy training, like to to give pharmacists, dedicated time for ID training, to attend training sessions, conferences, because many of the hospitals still don't give such opportunities to pharmacists or the financial support for them to do these. So do you think that that is also a good initiative, especially thinking from an Indian perspective?
Yeah, 100%. Training and educational is foundational. And luckily, there are some organizations that provide pharmacist training and education for little to no money. So that's one good place to start. Number two, having mentors and resources globally within India and outside of India is also important to help that training. And absolutely, it is very important to show administration that a pharmacist, once trained, once educated in ID, can really provide that benefit. And so these are the times when a small pilot program may actually
Mhm.
be the best way to start. So,
Right.
starting with a small intervention that you saw online or on a video, and then you implement that intervention, show the cost savings, and then demonstrate that these conferences will teach me a lot more, and I can
Yep.
have much more robust interventions going forward.
Yeah. And the third question that I have is actually you mentioned about using historical estimates, historical data to actually kickstart interventions to show that publications have shown cost benefits for this intervention. So we would like to implement this in our institution. But again, in an Indian context, we don't have local data on these aspects. Whatever we have is from international level. So would it be appropriate to actually use those estimates to say that even if we implement it, we could have say, similar benefits? Would it be appropriate?
Yeah, so I think that there are a lot of grassroots differences in the medical system. So I think it's tough to say that it is definitely appropriate, but
Hmm.
I'll tell you what I have done because even being in the US, being here, we don't have access to all this kind of information all the time. And what I found is that somebody has it. Somebody does have that information. And initially, it's a matter of finding out who that person is. So I've
Right.
had to set up meetings with finance or with quality, and they all track. So everybody's in their own silo. So I think identifying the right person
Hmm.
is the first place to start. And then there are increasing data in LMICs in India that have some more financial data. And actually, as I was preparing for this presentation, I learned a lot myself. And so I think using that data is a good place to start. And then also putting an asterisk and saying that this is a published estimate from a certain different population. This may or may not apply specifically to our patient population, but it's still a good place to start.
Hmm. Right, right. And I think lastly, I would like to really re-emphasize on what you already mentioned in your presentation, that is documentation is very, very, very important. I can't stress that enough because even now, there are a lot of pharmacists who are doing amazing work in India, but it is not documented, it is not published, and people don't know about it. So I think it's very important that pharmacists start documenting whatever they're doing, their interventions, their outcomes, and also publish their work. So marketing is equally important. So present your work at conferences, talk about your work to colleagues, to physicians, and that is, I think, how you improve your visibility and the visibility of the profession as a whole in our country. So thank you so much for actually reiterating that point because I think that's very, very important for us.
100%. There have been times when we published financial analyses on things that we thought nobody would find helpful because we're
Yeah.
at one hospital doing one intervention and saved $20,000 in an entire year, which is nothing compared to some of these bigger interventions. But all of that data is a starting point, and somebody will find that useful because there's
Yes.
another hospital and another pharmacist somewhere that has the same size and the same concern, and they can use your data. So definitely, please publish. Please get your names out there and get our profession's name out there.
Thank you so much, Dr. Karan Raja, for taking time out of your busy schedule for doing this wonderful presentation. I am very sure that the participants would benefit a lot from this. And like he said, if you have any questions, you can send it by email to FCPI, or you can post it as comments. We'll share it with Dr. Karan, and he will respond to those questions post the video is published. So thank you so much, and have a great day.
Thank you so much. Bye, everybody. Thank you.